There are currently two new medications available for the management of Alzheimer's disease. These are the first that we've ever had that we can actually say are disease modifying, meaning that they do slow down the progression of Alzheimer's. The first is called lecanemab, and the second that was approved is called donanemab. Both work on the same target, but they have slightly different mechanisms of action and slightly different dosing. How these drugs work is by targeting an abnormal protein called amyloid. Amyloid deposits in very high amounts in the brains of patients with Alzheimer's disease, and it is known to be toxic. These drugs are monoclonal antibodies, and what they do is bind to this amyloid so that your own immune system can recognize and remove it. Unfortunately, not every patient with dementia will necessarily be a candidate for these medications. Because the drugs are so specific in what they target, with it being amyloid, patients who are not proven to have amyloid pathology would not benefit from these medications. Additionally, when these drugs were first studied, they actually failed in their clinical trials because their cohort included patients in multiple different stages of their dementias. And what was discovered was that patients with moderately advanced or more advanced dementia did not gain any benefit from these medications. So presently, these drugs are available to patients who are proven to be amyloid positive and who are determined via cognitive testing to be within either the mild cognitive impairment stage or very early mild Alzheimer's disease. For patients that are deemed to be good candidates, the evidence suggests that we can slow the progression of Alzheimer's disease by roughly 30%. Unfortunately, these drugs are not cures, and while the patients did progress more slowly, their cognitive decline did continue to advance over time. There are some significant risks to consider with these medications, the most prominent of which is a disorder known as ARIA, which stands for amyloid-related imaging abnormalities. Basically what this is when your immune system attacks the amyloid, there can be some collateral damage. And this can lead to problems such as brain swelling or brain bleeding. The vast majority of these cases are discovered incidentally because we have very strict monitoring protocols in order to identify them. And we can pause the medication to hopefully prevent any significant damage to the patient. In some cases, though, including in the studies, the changes from that ARIA was so severe that the patient did suffer permanent deficits. And in a few very rare cases, there were even some deaths associated with these medications. Both of the medications are infusion therapies, meaning that you would need to present to an infusion center for an IV in order to receive the medication. The dosing is a bit different between the two. Lecanemab is dosed once every 2 weeks, whereas donanemab is dosed once a month. As I mentioned previously, aside from just the dosing, there are differences with respect to mechanism of action of these drugs. And so the decision of which agent to consider will be a very important conversation between each patient and their treating physician. In addition to the infusions themselves, these medications will also require frequent check-ins with brain imaging. Both medications are such that the current protocols advise at least 5 MRIs within the first year of treatment alone. These medications are admittedly very, very expensive. Medicare plans have been covering them, Exact out-of-pocket costs could vary pretty significantly depending on each individual's insurance coverage. And of course, there are multiple factors to consider, not only the cost of the medication, but any costs related to the infusion center, the MRIs, blood work, etc. So for patients who might be candidates for these therapies, the first steps generally involve a sit down with a practicing neurologist to have some cognitive testing. There's multiple different ways to achieve this, but ultimately we need to determine whether the patient is a candidate based on how severe their cognitive impairment appears to be. If they are a candidate, then we will typically proceed with more advanced testing in order to determine if amyloid is the driving pathology. There are currently multiple different ways to potentially confirm amyloid positivity. One would be a PET scan. These are very expensive, but generally insurance does cover these as well. There are also some new blood-based biomarkers. Several of these exist. Depending on which one is chosen, they all have different sensitivities and specificities. So your doctor will need to determine what is the best way to approach this confirmation. A baseline MRI would then be needed. Certain MRI findings might suggest that patients would be at highly increased risk of dangerous side effects and could therefore make them not a candidate. Careful review of all prior medical history and medications that the patient is taking, because given the risk of brain bleeding with this medications, patients who would already possibly be at higher risk for this might be determined to not be candidates. We generally also will get some genetic testing because there are certain genes that could place a patient at increased risk if they're present. Following all of this, if the patient does feel comfortable proceeding in pursuing these medications, and if their physician agrees that they are a good candidate, then submission to insurance for prior authorization and ultimately referral to an infusion center would be the final step.